And I was delighted to hear from our first speaker now, Hugh Kane, who's the new CEO of the Mental Health Commission, that he actually looked up some of what I had said myself during the passing of the Act, and some of the things that are going on aren't quite what we expected, right enough. Now, Hugh is our first speaker, and he's talking on the Mental Health Commission Strategic Agenda 2010 to 2012 and key current issues. He's been in his situation for the last few months, as I said, and I suppose it's just about safe to say it, but before this, he was for 30 years in the HSE. Now, he was in the former Eastern Health Board as a mental health programme manager and so forth, and he had a special interest as well in children's services. So, Hugh, look forward to hearing.
Thank you, Chairman. I'm delighted to be in Cork, in exile from Dublin, so I hope you'll be easy on me as I proceed. I'm going to try to deal fairly quickly with four general areas. I'm going to talk about national policy vision for change. I'm going to comment a little bit maybe on current legal challenges within the system. I'm going to talk strategically about where the HSE is going in a general way. So we'll just see how we go along, and hopefully I can work through on the technology here. Under the legislation, it sets out very clearly what the remit of the Mental Health Commission is, and in section 33(1) it says that the principal functions of the Commission shall be to promote, encourage and foster the establishment and maintenance of high standards and good practice in the delivery of mental health services, and to take all reasonable steps to protect the interests of persons detained in approved centres, and there was a lot of discussion this morning about that. So just to look at some of the key issues, as I said. In 2005, a government produced a policy, it's called a Vision for Change. And in this policy it describes a comprehensive framework for building and fostering positive mental health across the entire community and providing for accessible community-based specialist services for people with mental health and illness. And we all say, touché, that's exactly what we want. It's an excellent, excellent policy. But as usual, I suppose, in our country, we're great at writing the first part and we run into problems when we move on to try to do something about it. So when we look at implementation for Vision for Change, we're now into, it's 4 years since it was launched. Our own commission undertook a study of the implementation thus far, and we completed a piece of paper in late 2009 described from vision to action with a question mark. And I think based on our analysis, we're very clearly saying that the implementation plan that currently exists to implement Vision for Change isn't detailed enough. It's too fuzzy, and when something is that unclear, it doesn't really happen. The next issue we identified as a major issue was that in terms of the people who are going to drive through the Vision for Change, that there was a need for accountability, for effective leadership, and effectively someone who will take responsibility for bringing about this particular change in mental health services. And I think the kind of model we think about is, if you look at the approach that was taken to developing and rolling out the new cancer strategy, that there was one person with all the resources and actually made it happen. And we see that is a particular gap as well. The other piece as well is that both the resources need to be provided and how they're used need to be used very efficiently. And the other piece as well, that the long promised closure of the old style institutions isn't really happening at a pace that's required. So I suppose in one line, as a Mental Health Commission, we're certainly frustrated at the slow pace of change. As it is a legal conference, I thought I just might put out some of the legal issues, and these are not exhaustive, but certainly some of the issues that as a Commission we're concerned about. As other people have said, we see an urgent need for the capacity legislation. And again, in operating the Mental Health Act, there are lots of people who, as people described, are voluntarily detained, and there are huge issues around determining how free is that decision that people have made. And we think that that this legislation is absolutely a requirement, and it will assist all of us, people like ourselves trying to administer in the Commission, practitioners, people delivering service on a day-to-day basis, and indeed the lawyers and other people in the tribunals, but it's absolutely essential. The next one that's around there, section 59, is about ECT, and I suppose the major concern here is the Commission has recommended to government that there be changes in this particular section. the piece, we're not commenting on the efficacy of ECT or not, but we certainly are very, very clearly saying that if somebody has the capacity to make a decision, that the words "or unwilling" should be removed from the legislation. So that very clearly, if somebody knows their mind and says, "I do not want ECT," well, that has to be the end of the discussion on that particular thing. And we would certainly be pushing very hard for that particular change to come about. The other areas, and it was mentioned again this morning, section 23, 24, the Act refer to people who go in as voluntary and switch over to come involuntary. And again, we certainly are asking questions about how really voluntary am I if I'm in a unit that's locked, or if I decide I want to go, I can be detained. And the whole process where somebody changes from being a voluntary patient to an involuntary patient, we think we need to have the processes that are there for people who are involuntary, so that you go back and you are seeing a family member goes to a medical practitioner who assesses you, and you go through that particular protection that's there. And we again would think it's really important that we get some change there. We have mentioned today, there's been a lot of talk about tribunals, and one of the issues for us in the Mental Health Commission and as a state, we're spending €10 million each year running tribunals. And one of the things you want to be sure when you are spending that kind of money is that the tribunals are actually doing what they were intended to do, and they are bringing about a real change for people who are using mental health services. And I suppose the question for us is under section 49, it says that all tribunals shall be held in private. So if we want to conduct any research-based analysis of what's going on, or if we want to examine what's actually going on within the tribunal, how the tribunals are performing, we feel that section 49 doesn't particularly allow us to do that. And as the chairperson said, I was reading the debates ahead of this legislation, and Dr. Henry was asking the question, what about bona fide research or bona fide journalists being in? And at the time that it was decided that there wouldn't be that kind of an access to a tribunal because of the nature of the issues that have been discussed there. But I think in terms of trying to measure the performance of that, we would feel that we would need some powers in that particular area. The next major issue that I'm just throwing up there, again, I think where children are admitted to approved centres, the legislation provides that the child may have access to an independent legal representative, and I think we would be saying it should be stronger than that. There should be an automatic right to that, a garden ad litem system. And the final point really, and it's been discussed again here this morning, best interest, it's not really, it isn't defined at all in the legislation, and in the absence of a clear definition there, we get into the kind of discussion we had this morning. Different people trying to determine what is in the best interest or not, and I think it would be helpful if that best interest was defined a little bit more. And just to say that again, the Commission, we did produce a report on the operation of Part 2 of the Mental Health Act, and these issues and lots of others are included in that particular review. Just moving on, another piece, a huge piece of work that the Commission undertakes in addition to running tribunals is that we do appoint an Inspector of Mental Health Services who reports annually on the state of mental health services. So just at a global way, when you read the Inspector's report, which is on our website of 2009, in relation to approved centres, he's saying that the compliance with the rules, the regulations and the codes of practice, that generally the rates of compliance are improving. I think at a global level, and again without getting into individual pieces, that at a general level he wasn't satisfied that the quality of care and treatment was improving at the pace that we all would have thought. I suppose one of the issues that we've been looking at is, and again I'm conscious a lot of the focus today is on people who are detained involuntarily in approved units, and they really are just the tip of the iceberg in mental health services. So under the Act, the Inspector has to visit each approved centre, and there are 66 of those, so he's obliged to visit them every year. However, we are trying to push out that the Inspector would begin to look at wider issues. So last year he looked at 10 day hospitals. He looked at 13 what are described as 24-hour residents in the community, and he also visited Clover Hill Prison, where there is a mental health service there. I think strategically, and where we need to get to, is rather than approving 66 centres, which is just the tip of the iceberg, as a Commission where we want to go is that we would rather than approve just the approved centre, that we'd move towards a process of approving and licensing whole services, which includes the whole gambit of services that should be available within mental health services. And I think the other thing the inspector has welcomed has been the provision of new child and adolescent beds in Cork, Galway and Dublin. The other issues in terms of areas of concern, again he's highlighting the slow progress with poor buildings and poor premises. And again, as a commission, we're taking a particular focus, as we do licence and regulate these, we're going to take a different stance and approach towards buildings that he has described as being unfit for human habitation. So where we're moving towards is refusing licensing or approval for some of those particular centres, and people will see progress on that this year. I think the other concern the inspector is raising is that he's seen a big reduction in staff actually working in the mental health services. We have a figure that in 2009 710 nurses left the mental health services. And what's happening there is, instead of the services which we all want to recover, i.e. the services in the community and support, that there's been a retrenchment back into old style, the acute settings, which is not where we want to go. The other area he raised, and it's a bit linked with the other issue I mentioned earlier about the ability of people to determine whether they're voluntary or involuntary. Again, he's spoken about the inappropriate placements of a large number of patients with an intellectual disability in approved centres. And the final area is the whole issue of the admission of children to adult units. Now, the Commission is working towards the prevention of the admission of children into adult units. In 2009, we prohibited the admission of children under 16 to adult units. From December last, we moved that out to children under 17, and from next year we'll move it out to under 18, so that at this time, December next year, no children will be admitted to adult units. And if somebody wants to make a case for doing that, they'd have to establish in advance with the Commission that there's no other option there. And I think the analogy of the camel to the eye of the needle, I think, would be what the view that the Commission will be taking on that. Just moving very quickly along then, I just wanted to have a look at a strategic level in terms of where the Commission sees its role going. Our mission is to raise to the best international standards the quality of mental health service in Ireland and to protect the interests of people who use our service. So that's the mission that is driving us in our work. I suppose if you jump forward maybe to 2020 and use the analogy of 2020 vision, what we want at the centre are excellent mental health services, both for the general population, with good outcomes for service users, and that kind of a service would be based on best research and evidence. It'll be supported by government and political systems. There'll be a broad public support for mental health services and more coherent, wider sector links with all the other players who are involved. We're talking about local authorities, police, education systems as well. And again, I suppose in looking at our vision, we reflect the values underlying government policy, which is Vision for Change, and we endorse many of the aspirations. So very clearly we're saying that service users and their families are central to all services, and they're active players in it. They're not passive players, very active. We also believe that the human rights and best interests of service users have to be protected. We're focusing again on the quality of the therapeutic interventions and the mental health service, and that they are consistent with international best practice. That mental health services are provided by motivated staff equipped with the competencies that are appropriate to the services they're working in. And the public understanding of mental illness is deepening, and public attitudes are interestingly respectful, that stigma would diminish. And then finally, that policy planning and evaluation and care and treatment practices are evidence-based. So in terms of setting the agenda for the next 10 years, my role for the next 5 years is to try to drive through that particular mission and bring about that change. I suppose the other context I just want to mention for a minute in terms of demographic trends is that, as we all know, the population of Ireland is projected to increase into the foreseeable future, with a significant increase in elderly population. Between 2010 and 2026, there's a projected upward trend in the 65 and over dependency rates for Ireland and the EU, increasing from 16.4% to 21.5% in Ireland and 25% to 36% in the EU. There's a significant increase in the number of young people under 14 that's also anticipated. And again, as a society, we're becoming a multicultural society, which again poses additional challenges to mental health services. The NESF report in 2007 on mental health and social inclusion highlighted the consistent relation between mental ill health indicators of social inclusion. And again, just in the context of demography, I'm saying there are huge challenges from that particular perspective to people delivering mental health services and trying to bring about the change. The other piece I just wanted for a minute just reflect on, if you look at the graph there, that sort of indicates where the spend on mental health services in Ireland has gone from 1984 to 2005 and beyond. And if you look at it over that, between 1984 and now, in 1984 we were spending 14% of the health budget on mental health services, and in 2009 it's down to 6%. So again, in a context where you're trying to bring about huge change, where the demography is increasing, so the demand is increasing, and the budget is decreasing, I think it will present a particular challenge. The OECD actually would say that we should be spending about 12% of our health budget on mental health services. So at that level, we're about half of that at the moment. I suppose the issue for us as a commission really is we're not so much focused on the absolute level of funding. What we're more interested in is that we run services that are innovative and are cost effective. And I suppose in that sort of a context, I'm going to talk for a minute about having a balanced care model. And I think balance is really important in lots of things that we do. And when you look at developing a balanced care model, there is certainly evidence outside of Ireland that would give us some lessons that we might look at. You can see that right across the world there's a policy shift that's characterised by a move away from large institutions and asylums to community-based care. And all the evidence tells us that integrated community-based approach to mental health services delivery is where we need to go. But that no matter what you do in the community, there will always be some people who, because of their illness, will have to go to hospital. So that you'll always have to have that balance. You need good community-based services, but they'll also have to be supported by efficient hospital provision. So again, it's a matter, you need both pieces to it. I think the other thing that's really interesting is that good quality community-based care is not necessarily more cost efficient. But if you take a wider economic view of it, the outcomes for people who have mental health difficulties are much better when they're looked after and cared for in community-based services. And I suppose to make the shift from the very old style service that's generally seen throughout Ireland, there will be a need for some what I would describe as bridging finance to allow the development of new services. And when they're developed, you can give the money back when the older services behind are closed and sold on. I think the other thing that's really important is that to recognise is that families and carers provide a huge input to looking after people who are unwell in the community across a whole range of care areas, including mental health. And I think the other issue as well is the whole issue of encouraging and supporting people to have active participation in the workforce, because again all the evidence would say where people are not engaged or actively engaged in the workforce that they become socially excluded. So that's a way of driving social inclusion. Just to move on then, mental health services are largely provided by the HSE, and there are some voluntary and independent sectors involved. The HSE has a statutory responsibility to deliver all health services, including mental health services. As a commission, I suppose the HSE is going through what's described as a transformation programme, and we would really support their efforts to bring about more clearly defined clinical and administrative leadership at local level. We definitely support the creation of primary care teams and social care networks, and also the whole notion of supporting community-based services. I suppose one concern for us in that particular transformation is to ensure that specialist mental health services and professionals and the skills and resources that they have are maintained, because there is a risk if you move towards if you move towards a community-based service and take people out of acute hospitals, that those staff who are required to deliver the specialist mental health services could get lost. So just I suppose nearer to the coalface of the delivery, I think we feel that the current structures and staffing patterns in the mental health services present considerable challenges, and I think without going through them all there, you can see they're in it. I'll pick one particular issue though, and I think it is important to highlight it, that there is a government policy around a moratorium on the recruitment, and it's certainly impacting hugely in the delivery of mental health services, and I think it's something that needs to be considered. Just to talk about public awareness and stigma, again, there is stigma attached to mental health services. It's a root cause of discrimination and inequality and the disempowerment of people with a mental illness. And although the prevalence of mental illness is very high globally, there remains widespread ignorance and apathy and fear regarding mental illness. Recently there was someone who said that people who did have mental health problems would not put that on a certificate to give in to their employer. And I think if all of us think about that, if we were sick, would we be happy for a GP to write that we do have a mental health problem? That's what's stopping us going to work, that it causes a problem for us. So again, as a Commission, we're attaching high importance working on this issue with a whole range of service providers and service users, non-government organisations, educators, employers. And I think, again, the whole impact of mental health tribunals and different people getting insights and getting involved in mental health services, I think would help there as well. I think the Commission itself, very quickly, is quite committed to carrying out research and publishing information, and I think it's a key piece for us, and I won't go through the bullets on that one there. I just want to talk about engaging service users. They have a unique insight into mental health services, and they have a key role in the planning and the development of services. It's widely acknowledged that service users, their families and their carers are the most important stakeholders within the whole mental health domain. And as a Commission, we're fully committed to engagement with service users, their families and carers in all respects of developments. We have service users represented at our board level and on the inspector team, and service users are encouraged to contribute, right across a whole range of our activities, and you can see what I'm there. And our quality framework, which we developed in 2007, actually puts the service user at the centre of all our work, and again, it's trying to encourage mental health services to be involved with and facilitate an individual's personal journey to recovery. So that's it. Thanks very much. I just put up our website here because we've a huge range of research and publications information, and it's available there if people like to do that. Thank you very much.